mainly we are going to talk about today is the applied aspects of some common renal disorders. Okay, so we learn a little bit about common urinary symptoms, renal failure, and nephrotic syndrome. Okay, also about we are going to deal with the the renal function tests, and some associated topics like hemodialysis, peritoneal dialysis, renal transplantation, etc. So what are the common urinary symptoms? So one is polyuria. What is polyuria? The excretion of 3 liters of urine per day. Okay, and this is assuming that the patient is not on an increased fluid diet or an excessive fluid diet. So I want you all to be very sure of the definitions of some of these terms, which are very commonly asked in both, I mean, definitely in Viva, but can also come in theory. And I would say for that purpose, you should know what is polyuria, you should know what is oliguria, what is anuria, and I'll just take you through them. But be clear to establish a clarity about all these terms and the differences between them. Don't confuse them with each other. So what are the common causes of polyuria? So physiologically, it happens when there is primary polydipsia or excessive water drinking. Okay. Which can be psychogenic or even drug induced. For example, if one is consuming drugs like chlorpromazine or anticholinergics, there can be polyuria. So this is physiological. What can be the pathological causes? That means if there is defective water conservation by kidney. So that can happen in case of diabetes insipidus or solute diuresis, as happens in chronic renal failure, diabetes mellitus, and mannitol infusion. Or even in natriuresis, which occurs in salt-losing nephropathy and also due to effects of some diuretics. So this is about the pathological cause of polyuria. Then, so one term we learned was polyuria. Another term, important term, is urinary frequency. So that is increase in number of times a patient goes for urination. So polyuria is different from increased frequency, because in this case we measure the urine output for 24 hours. Okay. But urinary frequency is simply excessively the patient goes for urination. Okay. Then urgency of micturition. So that is an exaggerated sense or an urge to micturate. Why does it occur? Due to either irritative or inflammatory disorders of the bladder. This is often associated with increased frequency of urination. Okay. Then another important term is incontinence. So incontinence is the inability to retain urine and bladder. It results from either neurological or mechanical disorders of the system that controls micturition. What are the common causes of incontinence? So one is you have neurogenic incontinence, which occurs due to disturbances of neural control of micturition. Then there is stress continence, which often occurs in postmenopausal Paris women. Then there is mechanical incontinence, which occurs in case of any damage to the urethral sphincters. There is overflow incontinence, which occurs in obstruction due to benign prostatic enlargement. And there is Psychogenic incontinence, which occurs in anxious children. Okay, and even functional incontinence is seen in very old people who have mental derangement. So these are the different types and their associated different types of incontinence and their associated causes. Then what is enuresis? So that is involuntary passage of urine at night or during sleep. It's also called as night bedwetting or nocturnal enuresis. It's normal in children up to the age of 2 to 3 years. In some children, however, it takes a little longer for them to be able to have bladder control during night time. Then the other terms that I told you get confused often with polyuria and anuria. So oliguria is urine output less than 500 ml per day in adults. And it occurs in chronic renal failure and also in acute renal failure. What is anuria? So that is decreased formation or absence of formation of urine by kidney. And this occurs when the patient doesn't pass any urine or passes less than 50 ml of urine per day. Then nocturia is excessive amount of urine passed at night, and dysuria is pain or burning during micturition. So these three terms are almost always asked during the viva of renal system, that what is polyuria, oliguria, and urea. So be clear about their definitions. Then coming to renal failure. So renal failure occurs due to deterioration of renal functions. So what happens in this case? There is decrease in GFR and there is increase often in urea or other non-nitrogenous substances in blood. So I think we are well aware that there are two types of renal failure, acute and chronic. So acute renal failure means that there is sudden decrease or deterioration in GFR over a period of days or weeks, and that is associated with rapid increase in blood urea. And a chronic renal failure means that there is slow, insidious, irreversible deterioration of renal functions. And that can lead to development of a clinical syndrome of uremia, which is manifested by excretory, metabolic, neurological, hematological, and endocrinal abnormalities. So as a basic rule, remember that acute conditions are generally reversible. Most acute conditions. It's rather the chronic conditions that are usually, as mentioned here, they are slow to develop, they are insidious, they are often overlooked, and very often they are more difficult to treat or to reverse. So this table here shows you the differences between chronic renal failure and acute renal failure. So there is difference in onset, as I mentioned. There is, like I said, difference in reversibility. So as you see, mostly like most other acute conditions, even ARF is invariably reversible, but chronic renal failure is usually irreversible. Causes can be pre-renal, post-renal. Chronic, mostly causes are extra-renal. Urinary volume. So urinary volume will decrease. You might have oliguria and urea in acute renal failure. In chronic, you can have polyuria and nocturia. So, of course, an acute condition means recent onset of signs and symptoms of uremia in this case. And chronic renal failure, of course, any chronic condition means persisting at least for more than 3 months duration. Features, so sudden reduction in GFR and ARF, rapid rise in BP, urea and creatinine level, and high urine osmolality, more than 400 milliosmoles per kg water. In case of CRF, of course, we are talking about chronicity here, so the uremic symptoms would be present for a long duration. like there would be water retention happening, the kidney size would be decreased, there would be anemia, hypertension, and other associated conditions. Then the renal failure casts in urine are absent. We'll just learn about the urine investigation shortly. But in CRF, they are present. Specific gravity is increased in case of ARF, whereas in CRF, it is low and fixed. Past history of renal disease is absent in ARF, whereas CRF, it is present. Dialysis is required for short time in ARF, but for CRF, it is like a chronic maintenance dialysis required. And like I said, ARF, one may not need any extreme measure like a renal transplantation, but in case of CRF, it is the last resort often. So we don't need to go further into these because this is something you will learn in detail when you learn more about pathologies of diseases. Little bit now we'll touch upon the nephrotic syndrome. This is also very much a pathology topic. So nephrotic syndrome, it refers to a massive proteinuria. That means more than 3.5 gram per day, and mainly consists of albuminuria and its associated consequences like hypoalbuminemia, edema, hyperlipidemia, lipiduria, and hypercoagulability. So what are the events that lead to occurrence of nephrotic syndrome? So there are a wide variety of disease processes like immunological disorders, toxic injuries, metabolic abnormalities, biochemical defects, and vascular disorders which involve the glomeruli, and they contribute to development of nephrotic syndrome. So just have a look at this diagram here, this flow chart. So an inciting event will lead to glomerular injury. That will lead to two things: increased urinary protein loss, also we call as hypoalbuminemia, or inadequate hepatic synthesis of proteins. So hypoalbuminemia means less albumin is getting formed. This will lead to decreased oncotic pressure and edema, and increased synthesis of LDL and cholesterol, which will lead to hyperlipidemia and lipiduria. So overall, this leads to the development of nephrotic syndrome. So basically, very simply speaking, what is happening in nephrotic syndrome? There is decrease in synthesis of plasma proteins, broadly speaking. So there is decreased oncotic pressure. Because of that, the GFR increases. Now, because of prolonged GFR increase, ultimately there occurs tubular damage, and that leads to proteins leaking out. So that's the basic, those are the basic set of events occurring in the development of nephrotic syndrome. Now, diuretics, another topic you will learn in detail when you study pharmacology. But for now, as I mentioned, the role of diuretics in each part of the glomeruli and its parts when we talked about renal handling of each ion. So I mentioned which diuretics act on which part of the glomerulus and the nephron. So we've already learned a bit about that. So basically, diuretics are drugs which primarily cause net loss of sodium or natriuresis associated with water loss secondary to natriuresis, and so there is basically increase in the rate of urine flow. So if we classify them based on efficacy, then there are three types: high efficacy diuretics. These work by inhibiting sodium potassium chloride transport, and these are called as loop diuretics, for example, furosemide. Then medium efficacy diuretics, which work by inhibiting the role of sodium chloride symport. So example is thiazide diuretics like chlorothiazide. And then there are weak or adjunctive thiazides, which include carbonic anhydrase inhibitors like acetazolamide, potassium sparing diuretics like spironolactone, triamterene amiloride, osmotic diuretics like mannitol, isosorbide, and glycerol, and xanthines like theophylline. So these are your three types based on efficacy, and this table gives you the site of action of each. That's an important thing to remember, that what kind of diuretics act at which site of the nephron, and of course what is the mechanism of action, and then the major effects. So as I said, the high efficacy diuretics are acting at the thick ascending limb of loop of Henle, inhibiting sodium potassium chloride. And what happens because of that? There is increased sodium chloride excretion, increased potassium excretion, increased calcium excretion, and decreased ability to concentrate urine. Also decreased ability to dilute urine. Then your medium efficacy, and please do remember at least one or two names of each kind. Like furosemide is a fairly common, ethacrinic acid, these are fairly common names. For medium efficacy diuretics, they act in the early DCT. As I said, they inhibit the sodium chloride symporter and lead to increased sodium chloride excretion, increased potassium excretion, decreased calcium excretion, and decreased ability to dilute urine. Then your weak or adjunctive diuretics. So for medium efficacy, thiazide diuretics, chlorothiazide is a common one that we hear often about. In case of weak diuretic, carbonic anhydrase inhibitor, very commonly used, acetazolamide, you might have heard it often, acts on the PCT, inhibits carbonic anhydrase and increases bicarbonate excretion. Then you have potassium sparing diuretics. All these three names are common: spironolactone, triamterene, amiloride, act in late DCT and CT, inhibit sodium reabsorption, inhibit potassium secretion. They lead to increased sodium excretion, decreased potassium excretion, decreased hydrogen excretion. And finally, you have osmotic diuretics like mannitol, isosorbide, also both very commonly used in, again, PCT. They retain water isoosmotically and inhibit sodium chloride reabsorption. So they lead to increase in sodium, potassium, and chloride excretion. So this table is pretty important. Then there are, besides these, there are other substances which also act as diuretics. What are they? So water, it acts by inhibiting the antidiuretic hormone, ADH secretion. Then even alcohol acts as a diuretic. It acts by, again, same mechanism, inhibiting ADH secretion. Then your antagonist of V2 vasopressin inhibits action of vasopressin on collecting duct. Glucose, in case of diabetes mellitus, also acts as an osmotic diuretic. And caffeine, which causes increase in GFR and probably decreases renal tubular sodium reabsorption, also acts as a diuretic. Now, a very important topic from this lecture is renal function tests. So we had very briefly spoken about them in fact, I think the first unit itself, where we talked about renal plasma flow and about GFR, because we use these for the purpose of renal function tests. So basically, these are carried out to assess the functional capacity of kidneys for detection of any possible impairment as early as possible in its course, and any quantitative measure of change in function with time. So 2/3 of the renal tissue, it must be functionally damaged to show any abnormality of these tests. So they can be divided into these tests, like we do analysis of urine, of blood, then RCTs, renal clearance tests itself, then radiology and imaging, and finally biopsy. So let's run through each of these one by one. This is also very much a pathology topic. But anyway, we have to know a little bit about it at this stage. So first, coming to analysis of urine. So normal urine output. So before that, analysis of urine, basically, why do we do it? Again, for assessing kidney functioning. And in patients with suspected renal disorder, urine analysis should be performed for volume, specific gravity, osmolality, pH, abnormal constituents, microscopic examination, and even bacteriological findings. So first, in analysis of urine, we check for the volume. Is it normal urine output, which is around 800 to 2500 ml per day? Or is there an abnormality of urine volume, which we spoke about as the first topic today, whether there is polyuria, oliguria, or anuria. Then color of urine. So normally it is light yellow in color due to presence of urochrome pigment. Now once the urine is kept in a test tube for some time, the color deepens due to oxidation of urobilinogen into urobilin. Then abnormality of urine color includes, it can be brownish yellow because of presence of conjugated bilirubin in patients with hepatic and post-hepatic jaundice. It could have a cloudy appearance seen in strongly alkaline urine sample due to precipitation of calcium phosphate and that of urates. It could be frothy. It could have a frothy appearance, which means there is proteinuria, or it could have a red dark brown tinge, which is seen in porphyria. Then also we check for osmolality and specific gravity. The normal urinary osmolality varies, we already know this, from 50 to 1200 milliosmoles per kg, and specific gravity is from 1.003 to 1.030, depending upon the state of hydration. So if early morning sample after overnight fasting is collected, it would have an osmolality of less than 600 milliosmoles per kg water, and specific gravity more than 1.018, which means that the patient has normal urine concentrating ability. Now certain abnormalities are checked for. If there is fixed urinary osmolality of 300 milliosmoles per kg water with specific gravity of 1.010, then it's a fairly advanced case of urinary failure. If there is persistently decreasing urinary osmolality, less than 100 milliosmoles per kg water even after 8 hours of fluid deprivation, then that is diagnostic of diabetes insipidus. Then we check for urine pH. Normal urine pH varies from 4.5 to 8. Urine normally is slightly acidic except for short postprandial alkaline tide. So intake of increased protein or non-vegetarian diet, it shifts the urinary pH to the acidic side, whereas a vegetarian diet will shift it towards alkaline side. Then we do chemical analysis for abnormal urinary constituents. So normally up to around 150 milligrams per day of proteins are excreted daily in urine. And if the excretion increases above 150 milligram per day of protein, then this is called as proteinuria. So this normally occurs in conditions like congestive heart failure, in which you usually have a mild transient proteinuria, or there may be orthostatic proteinuria after prolonged standing, or there may be glomerular proteinuria in renal diseases, in which the permeability of the glomerular membrane is increased. So massive glomerular proteinuria is seen in the nephrotic syndrome, for example. Then there may be glycosuria, which refers to presence of glucose in the urine. It may be due to diabetes, renal disorders, GIT disorders, or other sugars like galactose and fructose may also be present in urine in certain inborn errors of metabolism. Then there is ketonuria, which refers to presence of ketone bodies like acetoacetic acid, beta hydroxybutyric acid, and acetone in the urine. So ketonuria occurs in patients suffering from ketosis due to severe diabetes mellitus or prolonged starvation. Then bilirubinuria refers to appearance of bilirubin in urine of patients with elevated conjugated bilirubin levels. This can occur usually in hepatic or post-hepatic jaundice. So normally 1 to 3.5 milligram of urobilinogen is excreted daily in the urine. But its excessive excretion, if present in urine, is a characteristic feature of hemolytic jaundice. Then we have hemoglobinuria, which is presence of hemoglobin in the urine, which indicates intravascular hemolysis. This is seen in black water fever due to falciparum malarial infection. And finally, we have hematuria, that means presence of blood in urine. This is seen in acute glomerulonephritis, AGN, and also in renal stone disease. Then we do a microscopic examination of urine, which means the examination of a centrifuged sediment of urine. And that may show casts, cells, and crystals. So let's learn a little bit about these. Casts are proteinaceous plugs, basically, formed by coagulation of TAM horseful protein. These are formed within renal tubules and washed out by flow of tubular fluid. They have a cylindrical shape, broken ends, and various shapes corresponding to tubule in which they are formed. They may be cellular or non-cellular. In cellular casts, certain cells are coagulated with protein material, and non-cellular casts are hyaline and granular casts. This is also very much something you will learn again in detail in pathology. Then crystals. So these are present in normal urine, and so they don't have pathological significance as such. Commonly seen crystals are that of calcium oxalate, calcium phosphate, calcium ammonium, magnesium phosphate, which we also call as triple phosphate, or uric acid. But when uric acid crystals and cysteine crystals, if they are present in large amounts, then they would have some diagnostic significance. And then third element I said, which is present in the centrifuge sediment, are cells. They are found on microscopic examination. So they may be RBCs, WBCs, tubular epithelial cells, or even squamous epithelial cells. Then we also do a bacteriological examination of urine. So for that, usually a midstream sample of urine is examined for pus cells and bacteria. Normally, urine samples would contain 1 or 2 WBCs or pus cells in a high power view. But if there is bacteriuria and pyuria, then that is indicative of a urinary tract infection. Then analysis of blood is done. So estimation of blood levels of substances that are excreted by the kidneys. This throws some light on the functional status of kidney, although these tests are less sensitive than the clearance tests. So what all blood tests do we do? We check for blood urea level. So normally it is 20 to 40 milligram per deciliter. and it's an index of glomerular function. The blood urea levels begin to rise after 50% glomerular damage has occurred. Then we check for plasma creatinine concentration. Normal is 0.6 to 1.5 milligram per deciliter. This is more reliable than blood urea, as the latter is subjected to variations by dietary proteins, hydration, and tissue breakdown. Then we check for serum protein levels. Normal protein is 6.7 to 8 gram per deciliter, out of which albumin is 3.5 gram per deciliter, globulins are 2 to 3 gram per deciliter, and Ag ratio, albumin globulin ratio is 1.7:1. So these are reduced if there is significant proteinuria with renal failure. In nephrotic syndrome, the albumin levels decrease and globulin levels increase, leading to reversal of Ag ratio. Then we check for serum cholesterol levels. So normal is 150 to 200 milligram per deciliter. These are increased in nephrotic syndrome. And finally, we check for serum electrolyte levels. So I'm sure you know by now the normal values, which are very important as students of physiology. So sodium generally 152 milliequivalent per liters, potassium 5 milliequivalent per liters, calcium 9 to 11 milligram per deciliter, then phosphate 3 to 4 milligram per deciliter, and so on and so forth. All these values are given, and these are altered in renal disorders. For example, in a case of chronic renal failure, there is mostly high potassium and phosphate, but the sodium and calcium levels are decreased from their normal ranges. Now coming to the most important topic from this lecture, which is renal clearance tests. So as I said, we had spoken about these briefly when we spoke about renal plasma flow and GFR and renal blood flow. So what is a renal clearance test? It's a test in which we show that the volume of plasma that is cleared of a substance in 1 minute by excretion of substance in urine. It is a virtual volume. So if I tell you that the renal clearance of X substance is 90 ml per minute, what does it mean? So a lot of people get this concept wrong. What it doesn't mean that 90 ml of that substance has been excreted. No, it means that 90 ml of plasma has been cleared completely of that particular substance in 1 minute. That's what a renal clearance means. So I'm going to say that again. Get the concept in your head cleared, that if I say that X substance has a renal clearance of 90 ml per minute, that means that 90 ml of plasma has been cleared of the substance X in 1 minute. So that substance has been completely excreted from the 90 ml plasma in a span of 1 minute. Okay. So the unit of renal clearance is ml per minute, and this is the important formula that you need to have on your tips. Okay, this is clearance, formula for clearance, where C is clearance and it is UV upon P, U being the urine concentration of the substance, V is the rate of flow of urine, and P is the plasma concentration. So this is the formula. Whenever we speak of clearance, you have to use this, whether you are solving a numerical or simply stating how clearance is calculated. Now, there are certain principles that govern the renal clearance of a substance. So, there are some substances which are freely filtered. What does that mean? That they are neither reabsorbed nor secreted. And such a substance is inulin. We have spoken about inulin earlier and we will again speak about it shortly. So in that case, the renal clearance of that substance is equal to the GFR, right? Because it is freely filtered. It's neither getting reabsorbed nor secreted. Okay, so it's equal to GFR, and such substances like inulin are called as glomerular markers. Then there are other substances which are freely filtered but partially reabsorbed in tubules. So in that case, their renal clearance rate would be less than GFR. Okay. Then there are substances which are freely filtered but completely reabsorbed. Okay, like sodium, glucose, amino acids, chloride, and bicarb. So they also have a reduced renal clearance rate than the GFR. And then there are substances which are filtered and also secreted by tubules but not absorbed. For example, para-amino hippuric acid, and diodrast, they would have a increased renal clearance rate than your GFR. Okay, so they are entirely excreted by single passage of blood into the kidneys, and clearance of such substances represents the range of blood flow. Then basically, renal clearance is used as a very useful kidney function test. So the clearance of a substance is correlated more directly with status of kidney function, and it also shows a deviation from normal or the earlier course in case of if you are looking at renal damage. So now the renal clearance tests are used to assess different functions of the nephron. What are those functions? So RCTs are used to assess glomerular filtration, to assess tubular secretory capacity or TS, to assess renal plasma flow, renal blood flow, and osmotic and free water clearance. So if you recall, we have earlier talked about this, that GFR, how renal plasma flow and GFR are related. So GFR is accurately measured by renal clearance of inulin, urea, and creatinine. So what happens in a inulin clearance test? So inulin is a dye, okay, which is a fructopolysaccharide. It doesn't exist naturally in body. Okay, so inulin clearance is a measure of GFR because the volume of plasma completely cleared of inulin per unit time equals the volume of plasma filtered per unit time. We just spoke about it that it's neither secreted nor reabsorbed, it's freely filtered. So therefore it's equal to GFR. So if you measure inulin clearance, you will get a measure of GFR. So what are the properties that allow inulin clearance to give us a measure of GFR? So basically, as I said, it is freely filtered by the glomeruli, neither reabsorbed nor secreted by tubules. Secondly, it is biologically inert and non-toxic. Then it is neither metabolized nor stored in the kidney, and its concentration can be easily estimated in the lab. So that's what makes this a feasible method for calculating or measuring GFR. So what is the method for this for inulin clearance test? So to perform this test, a single bolus dose of inulin is injected intravenously, which is followed by a continuous intravenous infusion at a rate which compensates for its loss in urine. So this endurance is important to achieve a fairly constant level of plasma concentration of inulin. So the inulin clearance, and so ultimately the GFR is then calculated from the following values, as you can see. So urine concentration of inulin taken to be 35 milligram per ml, urine flow rate So you can see in this example how we are using this formula. So urine flow rate is 0.9 ml per minute. Plasma concentration given as 0.25 milligram per minute, milligram per ml. So clearance of inulin or GFR would be calculated by this formula, U into V upon P, as we just mentioned. So U is 35 into V, 0.9 upon 0.25. Okay, and this comes out to be 126 ml per minute. Is this not near about what our GFR values? Yes. So C inulin is equal to GFR. Now, what is the clinical application or the significance of inulin clearance? So basically, inulin clearance rate is also used as the indicator of plasma clearance mechanisms, and comparison of clearance of a given substance with clearance of inulin will give you very important information about renal transport processes used to remove substances from plasma. So if you have a look at this figure, okay, this is showing clearance of various substances, okay, and this is the clearance value and plotted against the plasma levels. So if you see, first look at the graph of glucose. So it is first at 0 because 100% reabsorption is occurring. 100% reabsorption of glucose is occurring initially. So here it's at 0 value. Then it increases as it reaches its TM value. Okay, and slowly keeps increasing and then becomes constant. Okay, and now it has reached very close to inulin clearance values, right? What happens in case of PAH? So PAH is not reabsorbed, but it is secreted basically. So starts from a very high concentration, and then as the carriers for PAH, so the concentration keeps increasing, but the carriers keep getting depleted, right? So when they get saturated, the secretion will decrease from an initial high value. The secretion of PAH will come down, and this will also eventually become close to that of inulin. Okay, so this is the trend for these substances. Now, this graph is important. You might get a question showing this graph. Look at creatinine also. It's starting from a higher value and then again becomes constant and close to that of inulin. So you might get this graph minus the names of these substances. So you need to know what the graph of each substance is, what trend it follows, so that maybe you are required to rename, put the names in this graph and complete it. Okay, so please get a clarity of this diagram. Then let's go on to creatinine clearance test. So even though creatinine clearance test is less accurate than inulin, but in clinical practice it is often preferred over inulin because that is a little more cumbersome, because it, as I told you, the method, it requires a continuous IV infusion. Now creatinine is an endogenous substance, okay, which is fairly constant. It has a fairly constant plasma value of 0.6 to 1.5 milligram per deciliter. It is filtered by glomeruli and only marginally secreted by tubules. So again, its value of clearance is very close to GFR. So its measure is fairly good method of measuring GFR. What is the method of creatinine clearance test? So creatinine content of 24-hour urine collection is taken and plasma concentration in the sample collected at midpoint of urinary collection period are estimated. So the formula C for each clearance is the same. C is equal to UV upon P. Now normal value is 80 to 110 ml per minute in adults, and it decreases with age. As the creatinine clearance is an index of GFR, it reflects normal decrease in GFR with age, right? Although plasma creatinine concentration remains constant because of decreased muscle mass. Now, what is the value of creatinine clearance as KFT in disease? So, plasma creatinine concentration, it varies in it is inversely proportionate with GFR, and a product of GFR into plasma clearance creatinine concentration is constant. So if there is decrease in GFR, it actually may be the earliest clinical sign of a renal disease, which means decrease in the functional renal mass. Then thirdly, you have a urea clearance test. So as you saw here, urea is reabsorbed, okay, and not secreted much. It's basically reabsorbed. So in case of urea clearance, it is less than GFR and influenced by protein content of the diet. Okay, it's how come? Because urea is the end product of protein metabolism, and after being filtered by glomeruli, it is partly reabsorbed by renal tubules. So urea clearance is not as sensitive as creatinine clearance for assessing renal function, because see, being heavily influenced by diet, it would be pretty variable. So not the best method or as sensitive as the others. Then, as I said, the renal clearance tests are also used to assess tubular secretory capacity. So secretion of para-amino hippuric acid. So this tells us about the tubular fluid via carriers in the proximal tubule by a transport maximum TM limited process. So the TM of PAH is 80 milligram per minute. So when pH is reduced, that means there is less pH almost completely cleared from plasma by the combined process of glomerular filtration and tubular secretion. When it is more than 20 milligram per deciliter, that means transepithelial secretory process is saturated, TM of pH is reduced, and the pH quantities secretion remains constant and independent. When TM of pH is reached, then clearance is progressively more a function of glomerular filtration. So it approaches inulin, and constant amount of pH is secreted up till the fraction of total amount secreted. And because the TM of pH is nearly constant, it is used to measure or estimate tubular secretory capacity clinically. So this is what I had referred in the graph here. How? Because it is getting secreted. Initially there's a high value being secreted, then as the secretion increases and the carriers get exhausted, then the graph goes down and becomes closer and similar to inulin. Then RCTs are also used to assess renal plasma flow. So the renal plasma flow can be calculated by applying Fick's principle to kidney. So according to this, the amount of substance excreted by kidney per unit time is UV, okay, is equal to RPF into the AV difference in its plasma concentration. So basically this is your formula for renal plasma flow. It's important that you know this formula. So here PA is concentration of substance in renal arterial plasma and PV is concentration of substance in renal venous plasma. U, of course, concentration of substance in urine, and V is the volume of urine excretion. So this is your formula for renal plasma flow, which you have got from, again, applying Fick's principle. So I had just mentioned, okay, this is the same. So this is a slide I had shown you in the first unit, okay, where we had said that the pH clearance method is used for calculating renal blood flow and renal plasma flow. So this is the diagram that I was just referring to. Okay, the same thing which I just repeated. When it is more than 20 milligram, then what happens? The secretion becomes, after a while, it becomes constant and ultimately approaches that of closer to the inulin. Now, what is the method of pH clearance? So, pH is continuously infused at low doses to keep its plasma concentration constant, and the RPF is calculated by the formula I just told you, U into V. So in this case, UPH upon PA pH minus PV pH, right? And then at decreased plasma concentration of pH, all the pH will get excreted into urine and none will be returned to circulation via the renal vein. So the pH concentration in renal vein is 0 and can be eliminated. So now this is how the equation turns out. This gets subtracted. Now, since we know that U into V upon P is clearance of pH, right? So this is what the equation becomes. The RPF is equal to clearance of PAH. Now, to obtain true RPF, it's important to divide the clearance of pH by 0.9. And on doing so, we get RPF value of 690 by 0.9, which is 700 ml per minute. Okay. So now 10% of total renal plasma flow perfuses non-excretory function of kidneys. And so the RPF calculated from clearance of PAH is called as effective renal plasma flow, okay, or ERPF, as only 90% of plasma PAH is extracted. So this equation can be rewritten as ERPF is equal to clearance of pH. Now normally the concentration of pH in urine is 14 milligram per ml, urine flow being 0.9 ml per minute. Concentration of pH in plasma is 0.02 milligram per ml. So what will be the ERPF? U will be equal to clearance itself. U into V upon P, as we know. So the value will be 630 ml per minute. So now from value of true RPF, the value of renal blood flow, from the renal plasma flow, now the blood flow value can be also determined. So here now we are using the hematocrit value, okay? So what is the formula? Renal blood flow is equal to renal plasma flow into 1 upon 1 minus hematocrit value. Normally hematocrit is 45%, so on substituting these values, we get renal blood flow as 1273 ml per minute. So these are the normal values of ERPF, 650 per ml per minute for 1.73 meter square body surface area in males and 600 ml per minute per 1.73 meter square body surface area in females. And accordingly, the renal blood flow is approximately 1200 ml per minute. So see how you got both the values of RPF and RBF. using the clearance of pH. Now, renal clearance tests are also used to assess osmotic and free water clearance. So, what is osmotic clearance? It's the amount of plasma in ml which is completely cleared of osmotically active solutes that appear in urine per minute. So it measures the rate at which the plasma is cleared of osmotic particles, and again same formula for osmotic clearance. C is equal to U into V upon P. Okay, this is how we write it. So here U is urinary osmolality, V is the rate of urine flow, P is the plasma osmolality. This is the difference. And the normal value of osmotic clearance is about 3 milliliter per minute. It's increased in osmotic diuresis and decreased in fasting or diet deficient in proteins. Then you have free water clearance or CH2O. This is a quantitative measure of kidney's ability to excrete water. So what does it mean actually? That the volume of water or solute free water, so how much water basically that must be removed or added to the flow of urine to make it isoosmotic to plasma. Okay, so it basically is a measure of ability of kidneys to generate solute free water. The true clearance, it is not true clearance because no osmotically free water exists in plasma. Okay, now free water or the solute free water is generated in diluting segments like thick ascending limb and early DT, where sodium chloride reabsorption and free water is left in the tubular fluid. Sodium chloride reabsorption occurs and free water is left there. Now, in absence of ADH, this solute free water is excreted and your free water clearance is positive. But in case of presence of ADH, this solute free water is not excreted but reabsorbed by late collecting duct and late collecting tubule and collecting duct, and the free water clearance will be negative in that case. Now this is just to clarify the concept that how is calculation of free water clearance done. So the clearance of free water is V minus C, where CH2O is free water clearance, V is urine flow rate, and C is the clearance, okay, the osmolality clearance. So again same formula, U into V upon P. So let's take an example here to understand this. So if the urine flow rate is 10 milliliter per minute, urine osmolality is 100 milliosmoles per kg water, and plasma osmolality is 300 milliosmoles per kg water. So how will you calculate free water clearance? This formula, V minus C osmolality. So V is 10 ml per minute minus clearance, osmolality clearance, this. So substituting value of U, okay, into V upon U osmolality and P osmolality. These are the values. You get free water clearance, which is in this case 6.7 ml per minute. Now there are some tests we do for tubular functions. So that they check for the reabsorption and secretory function of renal tubules. So one is a urine concentration test, which tells us about the ability of tubules to concentrate urine, assessed by measuring specific gravity of urine. So either after 12 hours of water deprivation or 12 hours after injection of vasopressin or ADH. So in either case, if the specific gravity of urine is more than 1.020, tubular function is considered to be normal. Then we do a urine dilution test. So for this, the patient is asked to drink 1 liter of water and urine sample is collected every hour for next 4 hours. Normally at least 750 ml, which is around 75% of urine, it should be excreted during this period. And at least one of the samples should have an osmolality less than 100 milliosmoles per kg water or specific gravity of less than 1.004. Then we have a urine acidification test. So patient is given NH4Cl orally, ammonium chloride in dose of 0.1 gram per kg body weight, and the pH of urine sample is tested and collected after 6 hours. So normally urine pH is less than 5.3, okay, because after being metabolized in liver, sodium chloride, it yields hydrochloride by this formula, okay. NH4Cl leads to NH3 plus HCl. Then there are other methods employed, okay, such as we have a micropuncture technique to analyze tubular fluid at different levels. Then we have a microcryoscopic study of renal tissue slices at different depths. And there is also microelectrode study to measure membrane potential of the tubular cells. Then, of course, we do radiology and renal imaging also. This is something, again, you will study in detail when you study radiology as a subject. So what all do we do in this case? A plain radiograph of abdomen, useful in detecting calcium containing radio-opaque renal stone. So you would have heard very commonly that X-ray KUB and an ultrasound is done very commonly to detect any renal stones. Then we do IV pylography. Here you can have a look. So it's performed by injecting a radio-opaque dye like a urographin, which is given IV, and the radiograph of abdomen is taken at short intervals at 1, 5, 10 minutes and after half an hour. Then very feasible and quick and easy to do is your ultrasonography, non-invasive, inexpensive, harmless method to evaluate size, shape, position of kidney and to detect any tumor, stones, cysts in kidney, and even those present in ureter, prostate or bladder. Then CT is done to detect any abnormalities in and around kidneys. Very similar things you can detect in an ultrasound also. Then radionucleotide studies, which are carried out by injecting radioactive compounds which are concentrated and excreted by kidneys. And the radioactivity is recorded by gamma cameras. Then renal biopsy is performed. This is performed percutaneously with the help of a needle. This needle is called as Wim Silverman needle. It's quite useful in diagnosis of patients with proteinuria of unknown origin or any unexplained renal failure with normal sized kidneys, and in systemic diseases also associated with abnormal urinary constituents. So what happens in this case? The biopsy specimen is subjected to light, electron and immunofluorescence microscopic studies. Okay, and this technique has increased knowledge and better understanding of glomerular and tubular diseases. Then I'm sure we all have heard about a process known as dialysis. So the term dialysis in a sort of physiological sense refers to diffusion of solutes from an area of high concentration to an area of low concentration through a semi-permeable membrane. And this is the principle that has been used to dialyze the blood of patients with renal failure, especially those who are developing uremia. When does uremia develop? When more than 75% of nephrons are damaged It is characterized by accumulation of nitrogenous waste products in blood, metabolic acidosis, and hyperkalemia. In fact, uremic coma is the terminal event in a chronic renal failure case, and it's attributed chiefly to acidosis and hyperkalemia. Accumulation of nitrogenous waste products, they contribute relatively less to the loss of consciousness in a case of uremic coma. Then we have types of dialysis. So by dialysis, the dissolved crystalloids of plasma, they pass through a semi-permeable membrane so that their levels are brought down to lower levels. So there are two types of dialysis, such as hemodialysis, or also called or an artificial kidney, or a peritoneal dialysis. So now let's learn about hemodialysis. Hemodialysis can save lives in many types of acute renal failure, okay, which are produced by reversible pathological processes, or especially, for example, if there is circulatory shock or mercury poisoning. This intermittent hemodialysis may prolong life of many patients in CRF, chronic renal failure, which may lead an active life for many useful years. Dialysis can partially replace excretory function of the kidneys, but remember, it cannot replace endocrine and the metabolic functions of kidney. Now, what is the procedure? So hemodialysis machine is also called as the artificial kidney. Hemodialysis is done in a hospitalized patient through IV line for 3 to 4 hours. During hemodialysis, the patient's radial artery is connected to the hemodialysis machine. Inside the hemodialysis machine, the blood is passed through a long and coiled cellophane tube. So have a look. It's passed through a long and coiled cellophane tube immersed in a dialysis fluid. See here. Heparin is used as an anticoagulant while passing the blood through the machine. Okay. Now about the dialyzing fluid. So the composition of dialyzing fluid is similar to that of plasma, except that it is free of waste products like urea, uric acid, etc. The fluid contains less amount of sodium, potassium, and chloride ions than in the uremic blood. But the quantity of glucose, bicarbonate, and calcium ions are more actually in a dialyzing fluid than in the uremic blood. So this is the process of a hemodialysis. Okay, and then when the blood is passed through this membrane, hemodialysis membrane, okay, and inside this machine, the blood is passed through a long and coiled cellophane tube, which is immersed in the dialyzing fluid, and we use heparin as an anticoagulant, and then the toxins diffuse through the membrane. The purified blood is pumped back into the radial artery. Now, as I said, it can save many lives in case of acute renal failure. In case of chronic renal failure, it can perhaps prolong the life of some patients. And as I said, it can replace excretory function, but not possible to replace the endocrine and metabolic function of kidneys. Now, the second kind of dialysis is peritoneal dialysis. So, in this type of dialysis, the peritoneum is used as a semi-permeable membrane. There is continuous ambulatory peritoneal dialysis, which is a form of long-term dialysis done by the patients at home or at work. So what is the procedure like? So 2 liters of dialysis fluid is introduced through a permanent intraperitoneal catheter. It is then kept in the peritoneal cavity for exchange to take place for a period of 15 to 20 minutes, called as dwell time. The fluid is then drained out and measured. A strict input and output chart is maintained, and the whole procedure, it constitutes one cycle. This is done at 6 hours intervals, that is 4 cycles per day, even when the patient is ambulatory or mobile. So for peritoneal dialysis, there is no need for hospitalization. It's useful in young children and old patients with cardiovascular disorders, and it prolongs the survival in patients with chronic renal failure for many years. Now, this is a chart of differences between peritoneal dialysis and hemodialysis. So let me tell you that you often get a question in exam on hemodialysis or what is an artificial kidney. Okay. It's a very important topic. You might be asked about peritoneal dialysis also, or you can simply be asked about the differences between both. So when you're asked about the differences, basically you have to give the differences of indication for the two procedures. What are the indications? The differences in their methods, and what are they used for. So let's have a look here. Your peritoneal dialysis, the machine is not costly, but hemodialysis is a costly procedure. Peritoneal dialysis is less effective, hemodialysis is more effective. Peritoneal dialysis takes nearly 24 hours to bring down the urea levels from 200 milligram deciliter to 100 milligram deciliter, whereas a hemodialysis will take only 6 hours to do the same. Peritoneal dialysis may be uncomfortable. Hemodialysis is not usually. Here, the hemodynamic disturbances are less suitable to patients with coagulopathy. Here, the hemodynamic disturbances are more, and they may have hemorrhagic problems following heparinization. This may be done in patients with low blood pressure. This is difficult in patients with hypertension. Not very suitable for drug poisoning. Very helpful for drug poisoning or with toxic kidney, and not very effective in patients with gross overload. And this is the opposite, because the water can be filtered out very fast by hemofiltration. And lastly, let's talk about renal transplantation, which is sort of a last resort for a situation like an end-stage renal disease, for instance. So now the hemodialysis is, as we just learned, it's an expensive procedure and needs to be repeated almost every week. So it can't be regarded as a remedy in individuals with irreversible terminal renal failure, or what we call as end-stage renal disease. So this is the final answer to all the problems in a case of a chronic renal failure. It can reverse metabolic and excretory abnormalities. The graft is taken from a cadaver donor or from a sibling or a parent. Usually left kidney of a donor is transplanted to right iliac fossa of the recipient. And long-term immune suppression with prednisolone and cyclosporin is needed in this case, and it offers complete rehabilitation and is a more cost-effective option. Okay, so that's all for this chapter. So now what are the important topics? I told you hemodialysis, you can get a note on it, or even you can get differences between hemodialysis and peritoneal dialysis. Renal clearance is an important topic in itself, the most important. Okay, you must know the formula of clearance, whether to state it as part of a note on renal clearance, or whether to even do calculations. Okay. This is mostly to do with pathology. I told you these terms are very important. The common urinary symptoms. It's good to know the pathophysiology of nephrotic syndrome. Oh, this is very important. Yes, diuretics, this chart, the kind of diuretics with at least one example, the site of action, mechanism of action, and effects. This is important. Then it's good to know why you use, what makes inulin useful for giving measure of GFR, the qualities. Why would you not prefer urea clearance test? Why is it not considered as sensitive as a creatinine clearance? And someone can ask that why is creatinine clearance test more used in clinical practice? Why is it preferred over the inulin test? So again, that you will end up talking about the qualities creatinine has as a substance used for the clearance tests. This graph I told you can come minus the names, so you need to know the pattern of each of these substances: PAH, creatinine, urea compared with inulin, also glucose compared with inulin. Also, you should know the formula of renal plasma flow, how to calculate renal plasma flow. This one. Okay. Yes, dialysis, I already told you, is an important topic. Yes, so that's about it in this chapter. If you have any doubts and queries, I'll be happy to address them. If you want to do that later, you can send them through Gauri, and I'll be glad to get back to you on them. So shall we end today's session if there are no more doubts and queries? Okay, so I hope this topic is clear, and you are also aware of the important questions that can come from this topic. Okay, so thank you very much and have a good day.